would like to introduce Dr. Anil Kothari as a senior phaco and refractive surgeon and a managing director of Dr. Kothari Eye Hospital at Udaipur. And we look forward to.
Yeah, this is a hard brown cataract. I am a SI surgeon, CS surgeon also, but sometimes I always try if I can perform the cataract in hard cases also. So this is a very hard cataract. After doing a good capsular access, once the capsular access is over, take the chamber with the backpass, viscoelastic, doing stopping, trying to make a groove tunnel. It's very hard, 5 to 6 grade. It is very hard, and that's why I am feeling some difficulty in making a groove. Now I am trying to separate it. Now again pleat it with viscoelastic and trying to break the nucleus. Still you can see it's very difficult to break the nucleus. I am trying to rotate it and finding a way to break the nucleus. Trying to rotate it. A part of the nucleus has come in the antechamber and could break it. Now, with the help of pick-one and the hook, I could eat the pieces at the papillary level.
Thank you very much, Dr. Anil Kothari, for yet another way of doing the surgical procedure. But more for the sake of discussion, I would say that when we are doing a chop, you could either do your direct or horizontal chop, or sometimes it makes sense to create a small crater which allows you to bury your phaco tip deeper and get a better purchase of the nuclear fragment.
Very sticky material. It was very tried hard,
Yeah.
but it was not possible to break the nucleus in the bed. And that's
Sometimes
why a
you can
part
even
of
convert to do a stop and chop and get it into pieces and then go ahead and chop, because when you have a large hard nucleus in the anterior chamber, the endothelium becomes a bit of a challenge, protecting the endothelium. So anything to add, Dr. Mohan?
I think He did the surgery very well. Only thing is, the whole nucleus was in the anterior chamber.
Not
And if
whole
you
of the
look at-
nucleus, but a part
Yeah.
of was there, and I could break the nucleus in pieces. So a
Yeah,
part was there in the bag, and the part was there in the anterior chamber.
Yes,
It was
right.
keeping out one side. obliquely.
Right.
yes, yes.
I was wanted to ask the question: why did you bring that part up?
Now you could-
Because you should have actually done the endocapsular technique of chopping instead of bringing that up. The biggest problem with the brown cataracts is that if you bring that nucleus up without chopping, and you can have a white cornea the next day. So because you are chopping, you are doing the phaco very close to the corneal endothelium. So that is the problem. So when I saw your chopping, you're doing a lateral separation, but there is no vertical what you call force. So if you need to have a vertical force first, so that you can separate the posterior nuclear plate, and then once you have the vertical force, then you do the lateral separation. But when I saw the chopping, you're straight away holding it and doing only the lateral separation, which means that is the reason why it is not opening up the posterior nuclear plate.
Okay.
That's an observation which I just, yeah.
Had the trench been a bit deeper, then it would have been easily separated.
Yeah.
And was I the only one who observed that there was a surge when Kothari sir took out the last piece?
Yes.
So it is always a good idea to mellow down your settings, to bring down your settings once you are at the end of your surgery, to bring down your flow rate and your aspiration, to avoid this because surge at the once you're having the last piece can be very, very dangerous. It can lead to posterior capsular tear as well.
Yes, yes. Thank you very much, Dr. Kothari. I mean, that was certain pearls which we gained from